atrial fibrillation or flutter in stable patient in the emergency. So if you cardiovert, it's an off topic. If you cardiovert atrial fibrillation synchronized, use 120 to 150 joule. If you don't synchronize, use 150 to 200 joules. So in emergency, for rate control, use diltiazem, which is a calcium channel blocker, and you can use metoprolol. Diltiazem is 15 to 20 mg over 2 minutes. Then you can repeat the bolus, and after the start infusion, transition to oral diltiazem 60 to 90 mg, and stop infusion 2 hours after the oral dose. Metoprolol is 5 mg IV, may repeat every 5 minutes to total 15 mg, यानी कि 3 times you can repeat the 5 mg bolus. Then once you are satisfied with the rate, give metoprolol 12.5 mg for every 5 mg IV given के लिए, है ना. If you want मतलब ये दोनों diltiazem और metoprolol रेट कंट्रोल कराएंगे. If you want a rhythm conversion, you can use synchronized cardioversion. For atrial flutter, very low dose is required, 25 to 50 joules. For fibrillation, 150 to 200 joules is required. If you are going to convert the rhythm by drugs causing pharmacological cardioversion, you can use ibutilide, procainamide, flecainide and varnaloclint. If you are using ibutilide, 1 mg IV over 10 minutes is given. If you want to discharge a person with persistent atrial fibrillation or flutter, see his saturation. SpO2 should be more than 95% and heart rate should be less than 100. For non-valvular AF, not converted to sinus rhythm, calculate a CHA2DS2-VASc score. If it's 0, then no anticoagulation is required. If it is 1, either no anticoagulation or start anticoagulant. How do you decide? You calculate a Hasblad score. If CHA2DS2-VASc score is more than or equal to, you need to start oral anticoagulation and follow up within 7 days to you or cardiology. Arrange an OPD echocardiography before discharge, at least one echo before discharge. What is Hasblad score? So it is a score which is designed to know the risk of bleeding after anticoagulation in a patient. So H is for hypertension, A is for abnormal renal or river profile, S is for stroke, B is for bleeding, L is for labile INR, E is for elderly, more than 65-year patient, and D is for drugs or ethanol. All of these 7 parameters get 1 point each if positive. How do we interpret this? If the score is 0 to 1, you can continue, like up till 2, you can continue anticoagulation without any worries. For 3 to 5 and 6, consider alternatives to anticoagulation. What are the different rate control and oral anticoagulation medications which are used to discharge the patient with persistent atrial fibrillation or flutter? First is diltiazem. It is 60 to 90 milligram oral 4 times a day. Can be given. It is more effective than metoprolol in controlling heart rate. Avoid in patients with heart failure and reduced ejection fraction. Do not give calcium channel blocker to patients with reduced ejection fraction. Transition to extended release when you can know the total dose required. Metoprolol is given 25 to 50 milligram twice a day. Then we give anticoagulants. First is our OG, warfarin, which is preferred in prosthetic valve and rheumatic mitral stenosis patients. Warfarin 5 mg is useful in renal failure. In fact, it is preferred if the creatinine clearance is less than 15 ml per minute. As you know, warfarin is a vitamin K epoxide reductase inhibitor. So it acts on inhibiting all the vitamin K dependent anticoagulants factor 2, 7, 9, 10, protein C and protein S. Its half-life is 20 to 60 hours, mean you can take 40 hours of warfarin. So you know that we need to stop it at least 2 days before for the effects to wean off. Then other drugs are enoxaparin, but the caveat is it is a injectable, it's not available orally. Enoxaparin is given 1 milligram per kg subcutaneous BD in the therapeutic dose and OD in prophylactic dose. We need to half the dose if the creatinine clearance is less than 30 ml per minute. Next is dabigatran, which is direct thrombin inhibitor. 150 milligram PO BD is given if clearance is more than 30. If the clearance is less than 30, we give half the dose, which is 75 milligram PO BD. Then there is rivaroxaban and apixaban. They are factor 10A inhibitor. Rivaroxaban is given 20 mg daily and apixaban is given 5 mg BD. What are the ECG features of paroxysmal supraventricular tachycardia? There is absence of normal P waves. You will not find P waves because it is a AV reentrant tachycardia. AV nodal reentrant tachycardia. PSVT is AV NRT. That's why AV nodal blocker agent adenosine works so good in PSVT. You will not find normal P waves. We can find rare retrograde P waves if it is AVRT. There is normal QRS complex, usually less than 100 milliseconds in duration. In the first degree AV block, there will be prolonged PR interval more than 200 milliseconds. Normal PR interval is 120 to 200 milliseconds. If it is more than 200 and it is fixed, it is a first degree AV block. First degree AV block is normal. It can be caused due to increased vagal tone of any cause, medication toxicity, inferior MI and myocarditis. Its appearance can indicate an increased chance of progression to complete heart block. Wide complex tachycardias are defined as a rhythm with a QRS complex duration more than 100 milliseconds and rate over 100 beats per minute. So wide complex tachycardia. In complete heart block, the RR interval is fixed. It is normal. When in second degree Mobis type 2 heart block, the PR interval is constant. RR is not fixed. What are the ECG features of monomorphic and polymorphic ventricular tachycardia? In monomorphic, you will not find any P waves. There is occasional dissociated P wave. Rapid and regular. Wide QRS more than 120 millisecond with consistent beat to beat morphology. Every preceding beat is similar to the upcoming. All the beats look the same. While polymorphic is irregular, means the RR interval is not constant, plus the morphology is also different. Otherwise, it is also a wide QRS tachycardia without any P waves. In ACLS, procainamide dose is 20 to 50 mg per minute. Maximum dose is 17 mg per kg and sotalol is 100 mg over 5 minutes. Avoid these two drugs if there is prolonged QT. Why? Because sotalol is a class 3 antiarrhythmic, which is a potassium channel blocker, and procainamide is class 1A antiarrhythmic, which also blocks the potassium channel as well as the sodium channel. There is a Brugada's method. To differentiate wide complex SVT versus VT. So VT is diagnosed if analyzed in a sequence and any one of these four is present. So to call it an SVT, all of these should be absent. If any of these four is present, it is VT. First is absent of RS complex in all precordial leads. Second, R to S interval is more than 100 millisecond in one or more precordial leads. Third, there is AV dissociation. And fourth is morphological criteria for VT in leads V1 and V6. So V1 में there should be monophasic R wave, QR, QS और RS. And V6 में RS, QS, QR और S more than R हो अगर तो ये VT हो जाएगा. You need to treat a wide complex tachycardia as ventricular tachycardia unless proven otherwise. The thing is, if the patient is unstable, we are only going to cardiovert, and if the patient is stable, we are going to use antiarrhythmic drugs like amiodarone and procainamide. Coming to the treatment. Before treating the patient, consider if the undifferentiated wide complex tachycardia is due to either hyperkalemia or sodium channel blockade. Both situation require specific therapy, so drug history is important. If the patient is stable, assume the symptomatic wide complex tachycardia is ventricular and treat accordingly. So give shock in unstable. Don't waste time. In stable patient, the response to adenosine has been described as helpful in differentiating ventricular from SVT because SVT will respond very well to adenosine. But rare forms of VT can also be responsive to adenosine. Not all wide complex tachycardias require antiarrhythmic agents or urgent electrical therapy. You can consult a cardiologist. In ventricular fibrillation, there is no effective mechanical cardiac activity. VF can be fine VF or coarse VF. As you can see here, fine VF and coarse VF. Next, we will see Wolff-Parkinson-White syndrome. It is a form of ventricular pre-excitation. Means the ventricular is actually pre-excited about contracting. Actually, there is an accessory pathway because after the P wave, there is a delay because of the AV nodal delay, but it bypasses and the conduction reaches to the ventricle via an accessory pathway. That's why you see a slurring in the QRS complex after the P wave. So WPW patients are prone to a variety of SVTs. The PR interval is shortened and the ventricular is activated by two separate pathways, resulting in a fused or slightly widened QRS complex. So what you will see is a short PR interval, a delta wave, which is the slurring of the QRS, a slightly wide QRS. The most frequent dysrhythmia seen in the WPW patient is a reentrant tachycardia termed AV reciprocating tachycardia. It is an antidromic. The impulses goes back to atria through the accessory pathway. So we can see atrial fibrillation, antidromic AVRT, which is wide, An orthodromic AVRT, which is narrow, all can be seen in WPW, so it is very hard to diagnose. What is the ECG triad of WPW syndrome? It is PR interval less than 120 millisecond, slurring of the initial QRS complex known as the delta wave, and a slightly wide QRS complex. Remember and memorize this snapshot. This is a sinoatrial node, and AV node पे electric conduction is going, and then it is going to the ventricle via RBB and LBB, and there is an accessory pathway delivering the conduction without a delay to the ventricles. So if we block the AV node, the entire electricity will go through the accessory pathway and the heart will basically jam and fibrillate. Again, in this picture, there is an accessory pathway to AV node and AV node to accessory pathway, causing a AV reentrant tachycardia. Why not nodal reentrant? Because in the nodal reentrant, the entire circuit is within the AV node. There is no accessory pathway involved. Since accessory pathway is involved, it is AVRT. So arrhythmias can be antidromic and orthodromic. So this is a narrow complex or orthodromic, means the conduction is going from the AV to the accessory, then circling. Basically orthodromic is narrow and it is clockwise. While antidromic tachycardia is going away from the AV node to the accessory pathway, है ना. ऑर्थोड्रोमिक में accessory pathway से AV node जा रहा था ऐसे, but antidromic में AV node to the accessory pathway and then again. So it is an anti-clockwise sort of wide complex tachy. Next is Brugada syndrome. It is an inherited disorder of myocardial depolarization. In the congenital Brugada syndrome, there is mutation in the genes responsible for transmembrane sodium, calcium and potassium ion channels in the heart. How can you identify Brugada syndrome in the ECG? So in leads V1 to V3, the changes are seen. There are two types. Type 1, there is a coved ST segment elevation of more than 2 mm followed by an inverted T wave. As you can see here, there is a coved ST segment followed by an inverted T wave. In type 2, there is a 2 mm ST elevation with a trough in the ST segment at least 1 mm. So it rises by 2 mm and then depresses by 1 mm followed by a positive or a biphasic T wave, producing a saddleback pattern. So saddleback is Brugada. What are the high risk features in Brugada syndrome? If the patient is giving history of syncope, seizure or agonal respiration, if the family history of sudden cardiac death is there, and on electrophysiological study, inducibility of VT or VF is seen with programmed stimulation. Normal QT interval is 350 to 450 milliseconds. Let's complete antiarrhythmics. So there is a Vaughan-Williams classification of antiarrhythmic medication in class 1, 2, 3 and 4. Class 1 is your sodium channel blocker. Class 2 is your 2 for beta blockers. Class 3 is not C, है ना. Class 3 you will remember KCB, potassium channel blocker, is 3, and then calcium channel blocker is class 4. So CCB4 या CCD4 कर सकते हैं. CCB4 याद रखो, कैल्शियम चैनल ब्लॉकर क्लास 4, एंड KCB3. Again, class 1 is divided into class 1A, 1B and 1C. Class 1A is procainamide, quinidine something, and disopyramide. Class 1B is lignocaine. Class 1C is flecainide and propafenone. Class 2 is your esmolol, beta blocker, labetalol, metoprolol, except sotalol. Sotalol comes in class 3. AIDS, remember AIDS. Amiodarone, ibutylite, dofetilite and sotalol, and drondaron you can also remember. Class 4 is your diltiazem, verapamil and nicardipine. Class 1A prolongs action potential. Lignocaine, pharmacokinetics. It is as a hepatic metabolism, excreted in urine. Half-life is 30 minutes. Onset is 45 to 90 seconds. Duration is 10 to 20 minutes. Amiodarone possesses properties of all 4 classes of antiarrhythmics. Sotalol is used in monomorphic VT. So amiodarone blocks sodium channel, alpha and beta receptors, blocks potassium channel, blocks calcium, it blocks everything. So what it does on ECG? It prolongs the PRS and PR interval, prolongs QRS, prolongs QT. Avoid IV amiodarone in patients with WPW syndrome who have pre-excited AF as it is potentially harmful. So avoid amiodarone in WPW. Okay. तो बस procainamide बचा इस logic से तो. By this logic you can only give procainamide to WPW patients. That's it. In atrial fibrillation, amiodarone is not first line. Consider as a reasonable option for pharmacological cardioversion. Acceptable in patients with structural heart disease. It is a slow onset and average time to conversion is 24 hours. In VT, if there is a sustained monomorphic VT, it is a first line agent for hemodynamically stable VT. अभी तो थोड़ी देर पहले प्रोकेनामाइड बता रहा था, ये पागल है क्या? In VT, polymorphic VT not associated with long QT, it can be given. And pulseless VT VF में देते हैं. Dosing is the same. If it is ACLS, you can give 300 mg bolus and then repeat 150 mg bolus. If the patient has a pulse, you can give 150 mg in 100 ml D5 and bolus over 10 minutes. Then 1 mg per minute for the 6 hours and 0.5 mg per minute for the next 18 hours. If breakthrough arrhythmia occurs, you can repeat the 150 mg bolus. Maximum total daily dose is 2.2 gram. Amiodarone has a bioavailability of 35 to 65%. The volume of distribution is very high because it binds to plasma protein. Metabolism is by CYP450 in the liver. Excretion is in the urine and feces. And half-life is 9 days to 36 days. Nicardipine is used for the treatment of hypertension and it is contraindicated in patients with aortic stenosis.